this afternoon's presentation that will be given by myself, Diane Martins, along with Dolores Walters and Marie Jenkins Schwartz. To tell you, they'll both be talking about the history of childbirth and slavery, as well as healthcare in women. Dr. Walters became the Associate Director of Southern Rhode Island AHEC here at the University of Rhode Island this past March. She was formerly the Director of Diversity and Inclusion Initiatives at the National Council of Research on Women in New York City. In addition, she has served as a consultant on the Margaret Gardner opera, A Courageous and Tragic Story, which was the inspiration for Toni Morrison's Beloved. She discovered the story of Margaret Gardner while teaching and developing a national family local history training program at the National Underground Railroad Freedom Center in Cincinnati and Northern Kentucky University. Our other speaker this morning will be Dr. Marie Jenkins Schwartz. She is the professor of history and the chair of the history department here at the University of Rhode Island. She also is affiliated faculty in African and African American studies, as well as women's studies. Dr. Schwartz's research interests focus on the history of slavery, childbirth, and family. Her first book, Born in Bondage, Growing Up Enslaved in the Antebellum South, was released in 2000. More recently, Dr. Schwartz has published Birthing a Slave, Motherhood, and Medicine in the Antebellum South. That was published in 2006. I'd like to welcome both of our speakers. Today's presentations you will all receive a historical perspective on women's health care from slavery to the present. You will hear stories of control and stories of strengths and resistance used by women in spite of their enslaved state.
Thank you for that introduction, and thank you all for being here. It's good to see you all on this rainy day, so thank you all for coming. We had a wonderful introduction by Professor Martins, but you should all know that she teaches in the nursing department, the community health courses, and her work, and including her research and teaching, involves the homeless, the incarcerated, the hungry. And so we want to recognize her and provide an introduction for her as well. So I'm going to begin by defining what we mean by healthcare disparities or healthcare inequality. The term refers to gaps in the quality of health and healthcare that people receive across racial, ethnic, sexual orientation, gender orientation, and socioeconomic lines. According to the Department of Health Resources and Services Administration, HRSA, it refers to population-specific differences in the presence of disease, health outcomes, or access to health care. As we shall see in this slide and the next, healthcare disparities also refers to the ability or lack thereof of certain communities, especially the poor and communities of color, to prevent unhealthy products from being advertised in their neighborhoods. Next slide. Who is affected? Race and ethnicity are linked to the status of one's health, one's access to primary and preventive health care and services. Those who are affected include African Americans, Latino, Asian American, Native Hawaiian, and Pacific Islanders, who will be less likely to receive diagnosis and treatment for such diseases as AIDS, asthma, diabetes, prostate cancer, and a host of other chronic conditions, much less likely to receive treatment and diagnosis than whites. What prevents people in those communities from defining and establishing their access to health care? Economics and stereotypes play a very important role. Income is a factor, as access to lower wage jobs will likely eliminate the chances that low wage earners will have access to health care coverage. We want to place the continuing presence of healthcare disparities into a historical context with the intention that especially those who are interested in delivering healthcare services in training, as you as students and as teachers will gain insight into the continuing adverse relationship between access to healthcare, treatments and services, and such factors as income and education. Our goal is to facilitate assessments made by healthcare practitioners that will result in better outcomes for people in marginalized or underserved communities. Next slide. A case from 50 years ago illustrates the impact of history on present-day healthcare. Henrietta Lacks, who was born in 1920, was diagnosed with cervical cancer at Johns Hopkins Hospital in Maryland and was treated for cancer. But she died at age 31 in 1951. What was remarkable about the story of Henrietta Lacks is that while she was hospitalized, cells from her cancer were removed without her knowledge or consent. All right. It is thought that after those cells removed, or not thought that, what happened was the cells were reproduced in laboratories around the globe. And some sources say that the number of cells that are mounted from those reproductions can be weighed in tons. They're still being used today. So even though it may have been standard procedure to remove cells involuntarily from patients, it is likely that Henry Lacks, a black woman from the rural South who was poor and had probably little formal education, allowed her to be exploited in this way. There's a book out, a new book, called The Immortal Life of Henrietta Lacks by Rebecca Skloot. It just came out this year, which I would recommend if you want to hear more about her story. Another instance where blacks, in this example, black men, were used to gain advances in medical treatment and diagnosis, but themselves had no benefit from those experiments, was called the Tuskegee Experiment, in which black men were left untreated for syphilis for more than 30 years between the 1940s and 1970s in a government-run experiment. As I said, they did not benefit from the advances, but again, other people did. How many of you know about the Tuskegee Experiment? Okay, quite a few. Okay, the Tuskegee Effect refers to the distrust that African Americans still have of the medical system that results from their knowledge about this experiment. So despite the fact that healthcare disparities are known to exist and the fact that unequal access to healthcare is being addressed in this new Affordable Healthcare Reform Act, most people in the U.S., including most physicians, are not aware and do not believe that ethnic disparities exist in healthcare. Furthermore, while most nurses acknowledge that being competent in healthcare being competent to care for people from different cultures or backgrounds is a critical skill, competency training still needs to be more consistently and more comprehensively integrated into nursing education and practice. In her talk last night, Professor Dwana Fulwiley pointed out that cultural competency itself can be reduced to stereotypical representations of particular groups. So in implementing training programs, we want to avoid that error as well. Although these cases indicate that blacks in particular and people of color and others who were perceived as different in general have been marginalized in the U.S. healthcare system, there are also examples of women who have defied stereotypes of themselves, as we'll see in the next two slides. Margaret Garner was an enslaved woman enslaved on a plantation in Kentucky who escaped her enslavement with her family, crossing the Ohio River, which was frozen. They walked across into Cincinnati, but they failed in their escape attempt. And Margaret, seeing that her prospects for freedom were lost, killed her 2-year-old child in order to prevent her from being re-enslaved and from experiencing the kind of sexual abuse which she likely had experienced. It is thought that since her children were very light-skinned, except for the first child, who was probably her husband's, the others were fathered by the slaveholder, and so she was likely a victim of rape. It's a true story, the basis for Toni Morrison's novel Beloved and her opera, which is also called Margaret Garner. Now, this might not be a typical way that women chose to resist enslavement, but her story is instructive for us nonetheless. Another story is that of Harriet Jacobs. She used another method of resistance. Her dates are 1813 to 1897. She actually hid from the unwanted sexual advances of her slaveholder, who was a doctor, in a crawl space attic that she couldn't stand up in. She hid there for 7 years. Eventually, she was able to escape from North Carolina and reunite with her children. And just as remarkably, she was able to give a written account of her experiences. We don't have that many narratives of enslaved women. So this is one of the few. And it's her book called Life of a Slave Girl, which was published in 1861. On the right hand, you see a slave runaway ad, which was posted by Dr. Norcom, her would-be enslaver, would-be sexual abuser, who was trying to get her back in this ad. Let's go to the next slide. I don't want you to think that since I just talked about slavery that existed in southern states or border states like Kentucky, that slavery doesn't apply to the North. Some of you may know about the committee that was commissioned by African-American president of Brown University, Ruth Simmons, who wanted to explore the roots of Brown's founding in the slave trade. But we should also recognize that URI has evidence of its involvement in slavery. Ryan Stadium was built upon a plantation called the Niles Farmstead. So pictured here, you can see maybe, this is the scoreboard. This is part of the bleachers on the north end of Ryan Field. And this is a plaque that commemorates the burial ground of this Niles farm, where both African Americans and Native Americans were enslaved on that plantation. How many of you know about this plaque? About 3-4 people. Okay, how many of you have been to Ryan Stadium? Many more. Okay, well, I wanted you to know about this story. The plaque was dedicated in 2002, so not that long ago. But if we remain ignorant of a people's past, we appear less likely to grant them their full rights as citizens, including equal access to health care. For those whose descendants were exploited by slavery, exclusion, removal acts, or other means of discrimination that were passed by or condoned by our government, they're less likely to realize that their historical legacies of survival included those who did not accept victimization, exclusion, or enslavement, that they come from a people who survived injustices and abuse and have passed that legacy on to us. So now Professor Schwartz will provide us with another aspect of the historical dimension of women in healthcare.
You've heard some disturbing stories here this afternoon, and if I'm here to talk about enslaved women health care, it's not going to be very pretty either. And I want to acknowledge that when we talk about slavery, it is disturbing to all of us. But it's important, as the previous speaker said, to remember what happened. Most people, when they think of slaves, think of adults out in the field growing or harvesting cotton or some other agricultural crop. In fact, right before the Civil War, which began in 1861, half of slaves were age 15 or younger. 1/3 of all slaves were age 9 or younger. This is why I chose to write a book about what it was like to grow up enslaved, because I thought that if people didn't understand that children were enslaved and part of the story, they were not getting a full picture of what had happened in the past. It was the reason why I chose this watercolor for the cover of my book. This was a watercolor that was done in 1846 while slavery was still present in the nation, and it shows what I consider to be a more typical picture of slavery than that of the adult in the field. This is a family coming home from the field, and it reminds us that children were very important when it came to slavery, because if there had not been children born in slavery, slavery could not have continued. Enslaved people valued children for the same reasons we value children today. Having children was a chance to love and be loved. And for slaves, it was also a chance to remember and celebrate their human condition as opposed to their enslaved status. In agricultural societies, children worked. Enslaved children worked. And so they were of practical benefit to families as well as emotional benefit. Children did all sorts of things to help feed the family. For example, they could trap rabbits, they could pick berries, they could collect nuts. They did other things as well. They sewed and patched garments. They went out and got wood for the fire. They carried water in from the well, and they watched younger siblings and made sure they didn't wander off or roll into the fireplace while their parents were working in that field. But enslaved parents weren't the only people who valued slave children. Slaveholders, too, valued them. No small part of a slaveholder's financial worth was wrapped up in the birth of children. As of the 1st of January in 1808, the United States Congress made the decision to end the nation's participation in the international slave trade. There were no new slaves being brought in from Africa or the Caribbean. Instead, they knew that there would have to be children born in bondage enough to replace the number of slaves who would die off each year. So everyone knew that human reproduction was important to the continuation of slavery. Slaveholders knew it, enslaved people knew it, and so did physicians, a fact that's going to enter into the story here. There was a lot of money to be made in slavery, and everyone knew that too. You could make a luxurious living if you could get enough land and slaves, and people who didn't own slaves aspired to be slaveholders. By the time we get to the antebellum era, when I say that word, it means the decades before the Civil War, slavery was ending in Rhode Island and in other northern states. But that didn't mean that slavery wasn't of financial interest to people in the North. There were a lot of ways Northerners were making money off of slaves. For example, they were taking cotton and turning it into manufactured clothing, which they would sell back to slaveholders to clothe slaves. They were selling other kinds of commercial products that were grown by slaves, and they were doing things like insuring slaves, participating in the internal slave trade. Just because the United States wasn't importing slaves didn't mean they still weren't selling them within the country. And physicians were making money too, at least those in the South, who realized that it was pretty lucrative to get a contract to provide health care for enslaved people on a plantation. After all, you couldn't continue to make money on a plantation if your workers weren't healthy. And as I've pointed out, you needed to have children born in bondage. So when we get to the antebellum era, we begin to see slaveholders willing and able to pay physicians to come in and improve, in their view, the reproductive health of women. That translated into the idea that women would have children, be expected to have children, and that if physicians could do anything to help that out, then that would be paid for. And physicians, for their part, were happy to take on these contracts. At this time, physicians who had not been known for taking much of an interest in reproductive medicine before this time were beginning to experiment and learn how to use forceps and aid with difficult deliveries, childbirth. And they were taking an interest. Obstetrics and gynecology did not emerge as medical specialties until after the Civil War, but still there was this interest. So all of this kind of came together and ensured that physicians were beginning to treat or attend, I should say, enslaved women at birth. Now, this is the cover of my second book, and I chose the cover here to illustrate a story about medicine and slavery. This painting is by a modern artist, and it depicts a medical breakthrough of the late antebellum era. The physician on that side was J. Merriam Sims. Some of you may have heard his name. Have you? Has anybody ever heard of his name? He developed a cure for a condition called Vesica vaginal fistula. That was a terrible condition that sometimes results from childbirth. A tear develops in the lining between the vaginal wall, and the bladder, which allows urine to trickle from the vagina, and there was no cure. And the condition wasn't life-threatening, but it was very uncomfortable and socially isolating, because women who developed this condition from childbirth were hurt and they smelled, to put it quite frankly. Now, this condition isn't found in modern America. Because women who are in this position develops because usually the baby his head is too big to pass through the woman's pelvis, and the damage occurs as the baby's head hits against her soft parts during labor. Well, today those women in our country would have a cesarean section. But they didn't provide cesarean sections for this condition back then, because cesarean sections were experimental, and they almost always resulted in the death of the mother, the child, or both. Now, I do want to point out that this condition still exists in parts of the world where women can't get to clinics and hospitals, although it's been pretty much eliminated in our country, so it's still a problem. Sims is well known because he developed a cure for this condition. And he became quite famous. He became president of the American Medical Association, and he's often referred to today as the father of modern gynecology. But I want to tell you a little bit about how he came to develop his cure. If you look very carefully, you'll see three enslaved women depicted: Anarcha, Betsy, and Lucy. Anarcha is the one on the table. Sims performed medical experiments on these three women over the course of 4 years, always without anesthesia. He conducted experiments, 30 experiments on Anarcha over a 3.5-year period alone. He eventually found a cure, and he didn't stay in the South to treat enslaved women. He went north, where he found clients who were better able to pay and more able to celebrate his finding. Sims later downplayed the importance of these enslaved women in his experiments. He said that black women endured pain better than white women at one point, and he said that was one of the reasons why he chose to experiment on them, because not everybody was satisfied that this was the appropriate way for medical research to be done. Now, my book considers this and other cases involving doctors and enslaved women in the antebellum era to learn how medicine was practiced in the days when slavery was legal within the United States. And it emphasizes that medicine is more than clinical knowledge of the body. Medicine is about who gets what health care and why. Anarcha, Betsy, and Lucy got experimental treatment at the hands of a man who didn't know for years how he could cure them. Now let me go back to what I said about cesarean section. In the antebellum era, cesarean sections were virtually never performed because they usually resulted in the birth, in the death of the mother, the child, or both. There were cesarean sections performed, however, and virtually all of them were performed on enslaved women. This should give us some sense of who was getting experimental treatment in the nation, and ineffective treatment, too. There were other types of medical experimentation done on enslaved women. Virtually none of them resulted in a workable treatment. Sims was an exception. This was a success. Most were not successful. This was a day and age when doctors practiced what historians like to call bold medicine. That is, they tried to effect some kind of drastic reaction in the patient by purging, puking, bleeding, blistering, dosing with large amounts of medicine. Enslaved people had their own traditional practices, and they did not like the way the doctors practiced. Especially when it came to childbearing, enslaved women wanted to practice traditional means of birthing. They had their own ways, their own providers. They wanted to rely mostly on lay midwives, their mothers, and their friends to help them get through what many considered to be a very dangerous time for women. Enslaved people viewed the problems associated with childbearing as different from the way slaveholders and doctors viewed them. Enslaved people begged for better food. They asked for pregnant women to be excused from really difficult, heavy labor, and they pleaded that pregnant women not be subject to harsh punishments. Doctors did not consider these issues to be very important. Now, we know in hindsight that things like poor nutrition, harsh work regimens, beatings are very difficult for anybody, and pregnant women and their unborn babies especially. But doctors didn't see that. They were aligned largely in their thinking with slaveholders who wanted to view the situation in which women might have trouble with childbearing as a very narrow medical problem that somehow reproductive medicine might fix. For slaves, midwives were much more helpful than doctors. First, they could see the miserable outcomes that many doctors produced. But also, there were events that sometimes occurred during childbirth that required specialized knowledge and sometimes rituals. For example, the birth of twins, or the birth of a baby with the embryonic membrane across its face, also called the caul. Many people, not just enslaved people, but many people in traditional societies, believe that these kinds of events call for special knowledge and special rituals, and enslaved people were no exception. Mom Brown, a midwife in South Carolina, for example, who I discovered in the course of my research, knew how to make a special tea out of the embryonic sac, which kept people, or was said to keep the child from encountering and seeing supernatural forces. And a lot of women wanted this done for their children. No medically trained doctor could stand in for Mom Brown or other midwives because they didn't understand the cultural beliefs that guided behavior in the slave quarter. And so enslaved women looked for ways to protect themselves from physicians and their care. One of the ways they did that was to simply conceal their conditions. I encountered in my research enslaved women who, even when faced with life-threatening conditions, and they understood that and their families understood that, kept the onset of labor secret in the slave quarter, didn't tell the slave owner. Even when slave owners arranged for a woman to be attended by a physician in advance, the physician wouldn't know to come unless some slave said, well, so-and-so has gone into labor. So secretiveness became a way that enslaved women could maintain some control over their own bodies and see to it that childbearing went according to their own ideas of proper procedures. It didn't always work, but it worked well enough that in one case I found in South Carolina, a physician was called to the bed of a woman supposedly in labor. He waited for hours and to his astonishment learned there was no child. The woman had given birth in the field some hours before but had not told anybody because she wanted her child to experience the first hours of birth according to the way was traditional in her community. Slaveholders and physicians didn't like this. They thought that they should be in charge. They thought they had the right and the duty, and believed that their way was superior to that of the enslaved women. So I want to end with this thought. The practice of medicine in a given society is shaped by social structures and cultural beliefs. Patients and providers don't always share the same assumptions about how pregnancy, childbirth, or aftercare, or any other health matter should be handled. It's easier sometimes to go back in history and to see this in retrospect. It's harder to do it in our own times. I have given you some examples about how in the antebellum era, slavery shaped the way doctors understood and practiced medicine, and how enslaved women understood and experienced the practice of medicine. I would like to leave you with this question. What sorts of problems do patients experience today because of societal and cultural barriers that separate patients and practitioners? Thank you.
In large part, the recent Patient Affordable Healthcare and Reform Act was passed in order to address healthcare disparities. The Area Health Education Centers, the AHECs, were meant to address some of the healthcare disparities by, as you see there, fostering academic collaborations and improving the supply and distribution of a quality, culturally sensitive, interdisciplinary workforce that transcends these barriers and supplies even the most vulnerable people with the care that they deserved. Last summer in 2009, URI's College of Nursing became the host of the Southern Rhode Island Area Health Education Center, whose mission is to provide support and greater access to careers in nursing and other healthcare professions, and to improve the delivery of healthcare to the underserved communities in Southern Rhode Island. And we hope they'll continue to do that. It's supported by the Health Resources and Services Administration, known as HRSA. But I just want to leave you with the brief stories of two pioneers who are continuing the legacy of improved health care for people of color. On the left, you see Lula Owl Gloin, who was an RN and lived between 1891 and 1985. She was the first Eastern Band Cherokee public health nurse who spent her life improving the health care of the Cherokee people through direct service, political advocacy, and community partnerships. And on the right is Lucille See Dawson, also an RN, who died in 2000, actually. She was a member of the Narragansett Indian tribe and tribal historian, an authority on Native American studies. She obtained her BS from the College of Nursing at URI in 1959, and also her master's in education. And as you see here, she's being celebrated for being a nursing administrator. So these are a couple of stories of women that we don't usually hear about. And for certain, we have very few Native American students who graduate from the College of Nursing, and we'd like to address that. The AHEC is meant to help provide that kind of support. So we briefly outlined some of the advances in medical treatments and services and the fact that they're not equally accessible to everyone in the United States, and that this has a complex historical dimension. There are continuing racial, ethnic, cultural, and economic disparities that we have mentioned, but that's not to deny that there are other areas of concern, and some of these are being addressed. Language barriers, for example, have prompted hospitals to use translators and interpretation services. We also took a giant step forward this past April when President Obama mandated that the Department of Health and Human Services issue a directive granting visitation rights to lesbians and gays whose partners have been hospitalized. So cultural competence, I would end with thinking that cultural competence is essential to enable us to move beyond the mistakes and unwanted stereotypes of the past so that we can provide health care that recognizes the complex cultural identities of diverse individuals and groups. Thanks.
At this point, both Dolores and Marie and myself would like to open up for a few minutes of questions, whether it's questions about the history or the history of what we're creating at this particular moment in terms of not always being with cultural humility in our practice. Do you have any questions? It can be for Dolores or for Marie or for myself. Comments? Were there thoughts that you had as you heard the presentations? Yes, Dale.
It's about interpreters in hospitals. We are now very careful that we get qualified people that come in and act as interpreters. In the old days, when I was in practice, we often had people that were just in the hospital working in various and sundry kinds of jobs. And it turned out to be problematic because they often didn't know the dialect. They really weren't interpreters, and they didn't know how to explain things to patients. So we are much more careful in today's world. And all of you that are going into health careers should be well aware of that. You should have that in your facility.
Any other comments from the audience? Concerns? Were you aware of some of the history that you heard today? How many were aware of that history? One?
Okay. Did anything that we said surprise you? Were you surprised by some of the things that you heard? Yes. What surprised you? Come on. Why don't you pass that back to me?
Really, Brian Bonzo, a nursing student. It really surprised me because I didn't know anything about how they treat slavery, especially for women who's giving birth. No anesthetic, and it was just, my word is brutal. It's just plain brutal because they weren't being treated like regular human beings. So.
That's a good point. During slavery, individuals who were enslaved were not considered persons. They were considered property. So in the story that I told you about Margaret Garner, although she killed her child and she ran away, she was tried not for the murder of her child, but for stealing runaway property. So it's a very good point. Any other surprises? How do you think this will affect the way that you want to practice in the future? Will it affect you in any way? You guys usually so quiet? Yes.
My name is Donna Schwartz-Barca. I'm just wondering about the whole role been circulating articles about the role of nurses in the concentration camps, and how nurses at times would put their arm around someone in a caring manner when in fact they were giving a medicine that might kill them. So when you're talking a lot about medicine and deliveries and all, it does make me wonder if there's any history around the role of nurses. Were they really non-existent, like it sounds?
Yeah, another good point. In the story that I told you about the Tuskegee men who were who experimented on in the syphilis, there were nurses who were involved in that story as well, and knew that the patients were not receiving care for their disease. So very much in line with what Donna said. So yeah, you might have the opportunity to be supportive of a patient who has been diagnosed, and you see a treatment that might not be appropriate, and you might have the opportunity to do something about that. Okay, going once. Twice, I guess this is it then. Unless anybody else has anything to add or subtract.
Thank